Well, yeah, again, welcome everyone. I think we'll get it started. We'll have Dr. Schlesinger here. He's one of our colleagues at Hennepin Healthcare and Rheumatology is going to give a talk on cryoglobulinemia. So we'll turn it over to you, Dr. Schlesinger. And I think, Katie, are you running his slides? Is that right?
Yes.
Right.
Okay. So
we'll switch to the slideshow, right? Okay, good. Well, welcome. Thank you for inviting me, everybody. Yeah, I'm a very part-time member now of the Division of Rheumatology, winding down my career here in my 45th year, God forbid, of being at Hennepin. It's been quite a ride. Amanda shared with me her slides from a previous presentation on the hepatitis and lymphoma risk, which that helped me kind of get a perspective, also maybe emboldened me to I was impressed, Amanda, with how much immunology you gave the audience. So maybe I'm talking below you guys' level. I ended up putting relatively little immunology in because thinking about it, when I first was on faculty in the mid-late 80s, I kind of saw it both because I enjoyed it, kind of teaching immunology for the internists when the residents came through rheumatology, and because rheumatology is one of the few areas that really had a lot of penetration of immunology into clinical and lab use. Very different now with ID, HEMONC, all of the specialties. And I would be totally unqualified to do such a thing now. The national meetings in rheumatology have really almost become bifurcated, where clinicians can go to clinical sessions and the lab scientists see things that most of us would be glazed over very quickly. So it's been a burgeoning area in the last 20 to 30 years, largely because of the hepatitis C epidemic and the advancements in treatment for lymphoproliferative illnesses and the advent of biologic treatments. So next. As in the sign up, I'm going to just briefly describe the physical chemical properties of cryoglobulins and how they're classified. The system really came into being back in the 70s or 80s, and the basic classification hasn't changed really since then. Just to understand the associations between cryoglobulins and various medical conditions, and then just describe a general approach to treatment from the rheumatologist point of view. Next. So I will mention off-label use of rituximab for hepatitis C associated cryoglobulinic vasculitis. I mean, it is listed and up to date, so it's not a unconventional treatment, but it is not FDA approved for that, and I have no disclosures. Next. So what are cryoglobulins? And again, I'm not very good at watching for chats or raised hands. If somebody could point out if okay, I missed a question. So cryoglobulins, obviously cryo refers to the cold fraction. These are immunoglobulins that will spontaneously precipitate from serum in the cold. And it's critical for correct interpretation in the lab that the specimen be held at body temperature after it's collected, while you allow a clot formation and maturation to occur and centrifuge. That all happens at body temperature. Only then, after you decant the serum, do you refrigerate it, and then you look for deposits. And I think the lab will run it at least 3-4 days. You won't get lab results back, even if it's an in-house one, for several days. And then they should redissolve upon rewarming. So from up to date there on the right is a picture of the cryoglobulins at the bottom of the centrifugation tube, and then it redissolves upon rewarming. In our lab, I don't know if this is a send out. When they did them at the Hennepin lab, if it was just a small amount, it would be typically reported as trace or quantity not sufficient to characterize. If it was a large amount, they would report it as a cryocrit, so similar to hematocrit, what fraction of the serum is taken up by the precipitated cryoglobulins. So because of the way they're collected and maintained at body temperature until they're separated from the plasma, you are dealing with basically just immunoglobulins this way. Next. Again, this just go over a few things, and if again, this is the clinician and me talking, and if you have questions about it, you can ask now or later. We do see other phenomena clinically and in the lab in rheumatology clinic that are cold related, and just want to try to make a few comments on that. I don't have pictures necessarily. So acrocyanosis is a condition where the terminal digits, like the fingertips, turn bluish, upon cold exposure, and some of us who are cold sensitive might experience that. That's generally not a feature of connective tissue disease or cryoglobulins, except for the type 1, which we'll get to in a minute, the ones where there's a monoclonal protein. People with polycythemia can get acrocyanosis, but not so much the connective tissue disease patients. Raynaud's phenomenon, you're familiar, is classically, it's a triphasic phenomenon where the fingers, one or several, will, usually with a sharp demarcation around the MCP joint, they'll turn white, followed by blue, followed by red. So it's a vasospasm of the digital arterioles. The white is the vasospasm, the blue is like a reactive venodilatation, and the red is kind of a reactive hyperemia when it reperfuses. And it's often the later phases that are more painful. And when you see a classic or elicit a classic triphasic response, that's really good for Raynaud's. Most cases are idiopathic, 2/3 to 3/4. The remainder are divided between the connective tissue diseases and other diseases. And again, Raynaud's not that particularly common in cryoglobulinemia, particularly. Chilblains is another thing we see in kind of cold, damp climates. It's when people who often get exposed to cold, damp get kind of more like fissured and dry and discolored, usually toes. It's classically like in Britain and in the days before good indoor heating, but I do see it occasionally in young, usually women, especially athletic people who run outdoors in winter. And it sometimes creates worry on the patient's part that they could have something bad like Raynaud's connective tissue disease, but it's usually pretty easily diagnosed by derm. Biopsy is rarely necessary. Response to conservative treatment rarely evolves. And then livido reticularis is this kind of reticular mottled purplish color of the skin, which has a number of disease associations. It can be idiopathic. It's often under the fluorescent light in clinic, more prominent in tobacco users. We see it in lupus and antiphospholipid antibody syndrome. And we also do sometimes see it in small vessel vasculitis like cryoglobulinemia. So if you see this kind of spider net-like purplish color, especially if it's new or worse, certainly think that could be clinically significant. Any questions on those clinical features? And then just going to mention some of the other lab phenomena that are cold related, which are not so much rheumatology issues. So there are cold agglutinins, and these are antibodies, usually antibodies that usually IgM, and they attach to red cells in the cold. So it's either idiopathic or often associated with lymphoproliferative diseases like Waldenstrom's or something like that. The antibody will attach to the red cell in the cold to cause agglutination. And because IgM is an avid complement fixer, complement will get activated. Then when the blood returns to the core circulation, the IgM elutes off, but you can get complement mediated removal of the red cells through extravascular mechanisms. So it could cause a hemolytic anemia. We see it with mycoplasma infections. I'm not sure I've seen a case idiopathic or with the lymphoproliferative in a long time. There's cryoprecipitate, which is different from cryoglobulins, because in that case, you're chilling the plasma, not the serum. You don't allow that clot formation to occur at body temperature. and look at the serum only. So cryoprecipitate is rich in clotting factors, fibrinogen factor 8. They don't use the stuff so much anymore now that they have concentrated specific factors, but cryoprecipitate again is not cryoglobulins. And then there's yet another thing called cryofibrinogen, which is a naturally occurring thing. These are either dysfibrinogenemias or abnormal fibrinogens, otherwise that will cause some clotting and endothelial adherence during the cold. And there is some overlap between cryoglobulins and cryofibrinogens, so that this maybe about a third of people with cryoglobulins might have some cryofibrinogens. The reverse is not necessarily the case. Cryofibrinogens sometimes cause some distinctive skin changes, especially distally, like in the leg, where you often do get some ulcerations and necrosis. And treatment can be difficult because sometimes you can't treat the underlying disease, but sometimes lytic agents or other kind of anticoagulation can be tried, but again, you have to try to treat the underlying condition, which can be difficult. Any questions just on the terminology on that? Okay, so we're going to focus on cryoglobulins next. There's a classification system that has been in effect again for 30, 40 plus years. I know when I first worked in this area, there was a landmark article by French group Brouet from about 1985, but I think they just popularized the system. We talk about three types of immunoglobulins. Type 1 is composed of a monoclonal immunoglobulins, and it's usually IgM, because if a monoclonal immunoglobulin is going to precipitate in the cold, it's more likely a large molecule like IgM. Type 2 and type 3 are polyclonal. Type 2 has a monoclonal component, so you have monoclonal immunoglobulin targeting polyclonal IgG, or type 3, which is completely mixed polyclonal. You could have polyclonal M and polyclonal G, polyclonal M and GA, kind of all the above. So 1 monoclonal, 2 polyclonal with a monoclonal component, 3 mixed polyclonal. So based on that definition, it also turns out that type 2 and type 3 cryoglobulins also happen to be immune complexes. So not surprisingly, you're going to see these in chronic infections and autoimmune conditions where there are immune complexes. And they also fulfill the definition of a rheumatoid factor, which we'll just discuss in a minute. Next. So just to touch on the relationship between cryos and rheumatoid factor. So rheumatoid factors are autoantibodies. What's different about them compared to like a thyroid antibody or an ANA is they recognize self in a way. They recognize a domain on the Fc region of IgG. So you can actually have rheumatoid factors of different Ig classes, even IgA, but mainly IgM or IgG. They used to be done by latex agglutination, but I think they're done now more by a nephelometric method, and they're reported out as units, not as a titer. When you order an assay for rheumatoid factor, you're only getting IgM rheumatoid factor, because measuring IgG rheumatoid factor can be difficult because they serve as the targeter and the target. I mean, so they can target self. The antigen binding site will recognize the Fc immunoglobulin region of itself. So you'd have to do techniques to lyse the Fc region from the FAB region. So when you order a rheumatoid factor, you're really only getting IgM rheumatoid factor, and that's what all the definitions for rheumatoid arthritis are based on. If you say seropositive, you meaning IgM. Now it turns out in rheumatoid arthritis and maybe other diseases like cryoglobulin hep C, you can have IgG rheumatoid factor, and it may play a role in the pathogenesis of the synovitis in somebody with RA, but is probably not that important in the serum, except in rare situations. So if you were to draw a Venn diagram, most rheumatoid factors don't have cryoglobulin activity, but the converse is not the truth. Essentially, all type 2 or type 3 cryos are rheumatoid factor as well. Okay, so you could have a rheumatoid factor that's not a cryo, but all type 2 or 3 cryos that are mixed classes are going to have rheumatoid factor activity, but not type 1 because they're monoclonal. Okay, next. And there's just an example, like a three-dimensional view of a rheumatoid factor, and the domains that are shown there in yellow are supposed to be domains that are kind of projecting outward on the three-dimensional format of the rheumatoid factor, and those are the binding sites for the FAB fragment of the IgM rheumatoid factor. Next. So any questions just on the classification? Okay, so if we then move on to what are going to be the clinical manifestations of it, cryoglobulins can manifest clinically either through their sheer amount, and that's usually a type 1. Again, they're monoclonal, and this can include hyperviscosity, vaso-occlusive phenomena, or they can amplify their damage through their ability to activate the complement system, and that goes for type 2 and especially type 3. And the cardinal organs involved in mixed cryoglobulinemia would be those skin, joints, kidney, and peripheral nerves. So if we're seeing somebody in rheumatology with vague aches and pains, maybe they don't have objective synovitis, but they have what appear to be joint-centered achiness or maybe some neuropathic symptoms, these are the areas we're really going to cone in on, like even if they don't currently have active cutaneous vasculitis, do they have a history of a crop of lesions that could have been palpable purpura? Do they have a history of joint swelling? We would certainly check their renal function and UA for active sediment and proteinuria, even if their renal function were normal. And we try to do a careful peripheral nerve exam, either for a stocking glove distribution of numbness or for specific hits to peripheral nerves, like mononeuritis multiplex, like a wrist drop or foot drop. Next. So this just, I don't know why this table from an online text, this describes the concentrations in different units, whether it's milligrams per deciliter, like the middle column there on the second from the right, or the different units. Because the type 1, the monoclonal immunoglobulins, will cause their symptoms mainly through vascular occlusion, hyperviscosity, they're generally present in a lot higher concentration when they are brought to clinical attention. They're like 500 to 3,000 milligrams per deciliter. Whereas the type 2 and especially the type 3, because they're very avid complement fixers, might actually start to cause clinical trouble at a lot lower level, because again, you could get palpable purpura from a small vessel vasculitis at a point where the level is rather low still. And yeah, several of the articles I looked at mention the fact that just having cryoglobulins by themselves is not always abnormal. You do not always have to find a disease to go with it, just like in rheumatology, we sometimes have to interpret the meaning of a positive antinuclear antibody, and sometimes we just say it's positive with an uncertain significance, and we just have to watch the patients over time. So type 1s are typically present in a lot higher concentration when clinically detected, and they're going to cause their symptoms more through vaso-occlusion. Next. So from a review article, and a lot of this literature comes from the French. There's a French author, Patrice Cacoub, C-A-C-O-U-B. Some of these articles come from his group, and also from the Italian. So I could certainly, if you need any other references, we can provide those. So type 1 cryoglobulins are going to cause occlusion of the capillary lumen. True vasculitis with inflammatory cells in the vessel wall is uncommon, but you can get cold-induced symptoms and skin necrosis from the occlusion. Again, they don't usually have rheumatoid factor activity, and they don't always activate complement, whereas the type 2, type 3 do cause a true vasculitis with or without occlusion of the lumen. You get the palpable purpura, which is the quintessential dermatologic manifestation, and other things, or other less common skin findings. Rheumatoid factor activity is basically always present, and complement consumption is there. And there's a mix of different immunoglobulins, but usually IgM is part of it, but not the entire thing. Next. So again, this just goes a little bit more detail. I already mentioned skin, joints, kidney, neurologic system for the main things for mix. So if you look at the various skin manifestations, purpura can be present in both, but more in the type 2, 3. Raynaud's not particularly common in either. Distal necrosis, because of the hyperviscosity, more common in type 1. Aggravation by the cold, more common in type 1. Livido, not particularly common in either. Immune complex arthritis, more common in type 3. Peripheral neuropathy, either kind of stocking glove or mononeuritis multiplex with vasculitis of the peripheral nerves, more common in type 2 and 3. Renal, not uncommon in type 2 and 3, but CNS and other organ systems much less common. Next. So just some examples. This would be a kind of classic example of somebody with a small vessel vasculitis. Now, I don't know what the trigger was. It could be cryoglobulinemia from Hep C. This could be somebody with hypersensitivity vasculitis after a medication exposure. Could be a kid with Henoch-Schönlein purpura after a gastrointestinal viral illness, things like that. But the hallmark is there's involvement of small lumen vessel, typically the post-capillary venule, or the capillaries are the site, because there's complement activation in some cases, but certainly there's edema in the vessel wall, there's extravasation of red cells. So you do get a palpable purpura. The dermatologist will run their finger over it, and it's slightly elevated, to distinguishing it from, say, a thrombocytopenic purpura. Next, just some other examples. This one's a little bit more, maybe a little bit older. We're just, the lesions have been present for a while. Sometimes these come in successive crops. Sometimes there's just a one hit where there's just a single crop of one age. Other times they come successively. So this could be just slightly different morphology, a little bit older. Next. Again, this from an online, this is the DermNet, which has got a lot of great pictures. It tends to affect dependent areas. So like a kid with Henoch-Schönlein purpura or adult with Hep C, it's going to typically be lower extremities. If somebody's laying in bed, a distribution like this with the back and the buttocks, back of the thighs would be common. And you can almost imagine that this would be palpable if you run your finger over the lesions. Next. The cutaneous manifestations can become more pronounced and severe as well. These lesions can coalesce and ulcerate. Again, that patient on the upper left there who has this kind of angulated ulcer might perhaps have some cryofibrinogens or something along with it, and we would probably look at them for antiphospholipid antibodies, especially if we thought they had a connective tissue disease with cryoglobulins, not say Hep C. The upper middle panel is a biopsy of a nerve showing that there's been infiltration of inflammatory cells within the nerve sheath, and the vessels, the basal nervorum that nourish the nerve. So that person could have presented with foot drop or wrist drop if it hit a particular nerve. Upper right shows the stocking glove distribution. The involvement is usually dependent on the length of the fiber. So lower extremity more common than upper extremity, and distal more than proximal. Lower left is somebody with an immune complex cryoglobulinemic vasculitis in the kidney. So presumably this person had some combination of proteinuria, hematuria, decreased renal function, and it's typically a mesangial-proliferative, membranoproliferative glomerulonephritis. And the immunofluorescence would, and the other peripheral lab data would help support the diagnosis of cryoglobulinemic vasculitis. I don't think, I should say, once you diagnose cryoglobulins, trying to find an antigen in the cryoglobulin isn't necessarily fruitful. I don't think we necessarily try that. Trying to look for hep C antigen to see if it's the target. I do remember in the beginning of the HIV epidemic, we did somebody who presented with a vasculitis as her initial manifestation of HIV. I did think we tried to find antigen in the cryo, but it's not typically done. And then the middle bottom panel there is CNS involvement with some degree of edema or infarct on MRI. Okay, next. Okay, so so we've talked a little about the classification, the lab measurement, how the different types will manifest clinically, hyperviscosity versus immune complex and complement activation. So going on to disease associations, next. So this is my perspective as a rheumatologist. So everybody knows Dr. Fauci now as the head of the COVID effort nationally. But you all know that before that he was involved with the NIH response to the AIDS epidemic. But as a rheumatologist before that, next, he was an immunologist, and before AIDS, he really was an investigator for vasculitis and was involved, I think, in some of the initial NIH studies of what we then called Wegener's granulomatosis, now GPA granulomatosis with polyangiitis. And of course, that was all described before the ANCA antibody system was even known about. So this was one of my Bibles during fellowship and early staff years. This, I think, came out in 1981 or 82. And just to show you how the hep C, the ability to look for hep C and the epidemic changed kind of the way we look at things. This book didn't even have a section on, certainly not hep C, it was still non-A, non-B at the time, and not even on cryoglobulinemic vasculitis. Next slide. There was a chapter in here on hypersensitivity vasculitis, which I think included, drug-induced, maybe Henoch-Schönlein purpura. So within that was a section there called vasculitis with mixed cryoglobulinemia. So that was a large group of these patients. Hepatitis B had been associated with classic polyarteritis nodosa, which is a larger vessel, like a medium vessel vasculitis, and is a pretty rare disease. And that association was not that tight. So the people who did not have evidence of a chronic infection or a malignancy were called essential mixed cryoglobulinemia. But once hep C testing became available, we realized that the vast majority of patients with what were heretofore called essential mixed cryoglobulinemia really had hep C virus associated mixed cryoglobulinemia. Next. So I hate slides like this because you can't remember it all. From a review article, what disease associations did you think about? Again, and they take the liberty of bolding some of the things, which is good, that are more important. So remember, type 1 are going to typically be associated with malignancies associated with the production of monoclonal antibodies. So Waldenstrom's if it's IgM, or IgG or A if it's multiple myeloma, or MGUS, or B-cell NHL where there's production of antibodies. The classic autoimmune diseases for us would be Sjogren's and SLE, which are characterized by really unchecked B-cell proliferation and polyclonal gammopathy, in addition to the specific autoantibodies, and a lot less for some of the other conditions listed. Then you move up to the upper right there, infections. So I certainly think, I don't know why they didn't bold hepatitis C and to some extent B, but an HIV certainly, I don't think to my knowledge, I haven't been doing inpatient consults while we don't really see much cryoglobulin clinically relevant from HIV unless they have co-infection, but Amanda or someone else can chime in on that. And then other chronic infections like parasitic, fungal.
One question I had,
Yeah.
Dr. Schlesinger,
Yeah.
with the types, do the
Mhm.
numbers here correlate with the specific type of cryoglobulinemia? Is it type 1?
Well, the B cell would usually be type 1, and then group 2, 3, 4 would all be mixed typically.
Okay.
Is that
Thanks.
what you're asking?
Yeah, it's pretty
Yeah.
basic question. I just wanted to
Yeah.
clarify. I was a little confused.
Okay. Next. So yeah, so for us, in rheumatology, the primary rheumatic condition most likely to mimic HCV related cryoglobulinemic vasculitis is Sjogren's. So again, with Sjogren's, you can have sicca symptoms like dry eyes, dry mouth, xerostomia, xerophthalmia. And some of those patients go on and develop extraglandular features like polyclonic hemopathy, hepatic dysfunction, mononeuritis multiplex, renal, CNS. And you can have Sjogren's either secondary to a known other connective tissue disease like RA or lupus, or it can be primary. And I have not kept up on the pathogenesis of primary Sjogren's, but it is one of the most kind of intense illnesses as far as polyclonal B cell activation that we deal with. And certainly Hep C has a lot of overlap there. And yeah, Amanda or someone else can take this. During the elaboration of the HCV epidemic and the symptoms, do you guys think that HCV alone without vasculitis can produce arthralgias, arthritis, or not? I mean, that's been a debated question, and I've certainly had people say, yeah, these are achier people, but is it a false association? Is it that people with HCV are more likely are they pain prone individuals who are more likely to have, you've done recreational drugs and acquired HCV? Is it really the HCV or is it something else about the host? I don't know. But compared with rheumatoid arthritis, Sjogren's patients, they don't necessarily announce their disease as dramatically. They won't have juicy synovitis like an RA patient. They could come in with, they say they're achy, it's in a joint center distribution. They may complain of sicca symptoms. There's a lot of overlap between HCV and Sjogren's. And so it's certainly just part of our normal workup. And if you're going to call somebody Sjogren's, besides having inclusion criteria, either with or without a minor salivary gland biopsy, excluding HCV would be an important part before you could call somebody primary Sjogren's. Both Sjogren's and HCV increase the risk of lymphoma. And most patients with Sjogren's, like the little old lady with dry eyes, dry mouth, it can be a benign process, what you could call a benign autoimmune exochronopathy, because the lacrimal and the salivary glands are not working normally. They've been infiltrated by the immune system. They don't have normal secretory function, but it can progress in some patients to a malignant lymphoproliferative disease, and trying to decide where along the way you're going to intervene. In the more severe patients, the treatment is very similar to what we do for cryoglobulinemic vasculitis. Let's see. Okay. Yeah, maybe. Okay. Next. Yeah, a quick plug for this book. It's in its 4th edition. This is the online version. Sterling West was the director of rheumatology at University of Colorado. He's an impressive guy. I think he's retired now, but there've been several editions now. It's just be great for studying for boards, or if you just have questions. It's almost encyclopedic, where each chapter is like a series of questions. You know, for anything you want to look up, like EMG 101 or nerve biopsy 101, things like that. So what the rheumatologists have kind of evolved into doing now is a stratified treatment approach to HCV. You diagnose somebody with mild to moderate disease. They presented with recurrent purpura or articular symptoms. They either don't have any neuropathy or it's mild. They either don't have renal involvement or it's minimal. The consensus is, and there's really a paucity of very good randomized studies. There's a Cochrane review that fails to come to definite conclusions about the role of immunosuppressive therapy. But most people would go directly to antiviral therapy here, with or without the use of immunosuppressive therapy. And meanwhile, if somebody presented with more juicy synovitis with rheumatoid factor and CCP positive, you know, the antibody that's specific for rheumatoid arthritis, there we might say, geez, this is probably somebody who's got RA and happens to be HCV positive, and we'll treat for RA and for HCV. You know, maybe we'd pick a non-immunosuppressive medication like an antimalarial hydroxychloroquine to start with while we treat the HCV, and then let's see where things settle out. For kind of moderate to severe disease, so the skin disease is worse, they have more severe neuropathy like wrist drop or foot drop. They do have heavier proteinuria or renal failure. Most people would go directly to immunosuppressive therapy. And it used to be corticosteroids with or without cyclophosphamide. And with the advent of rituximab, it appears that rituximab is at least as effective with less adverse effect on the viral load. So either just minimal corticosteroids to begin with, and we always pulse people with it during the IV treatment anyway to prevent reactions, and then moving on to antiviral therapy. And if they either progress or have life-threatening disease like RPGN, severe CNS involvement, alveolar hemorrhage, we would go to plasma exchange, and then either rituximab or cyclophosphamide. Of course, yeah, remember, if you're going to give a drug as expensive as rituximab and you want it to work, don't time your exchanges so you don't exchange off your rituximab. And again, that appears to have minimal deleterious effect on the course of the viral illness, and then you can eventually proceed to antiviral therapy. But Amanda, you can chime in. I think we wait less now than we used to. You pretty much try to get antiviral going relatively soon, do you? Or, you know?
Yeah,
Yeah.
as soon as we can.
Yeah. So next, I think we're near the end here. Okay, and then just as, again, I saw Amanda's slides about the role of HCV in increasing the risk of lymphoma. There still appears to be a subset of these patients that, despite the advent of the directly acting antiviral drugs for Hep C, are at risk for having a flare-up of a relapse of the cryoglobulinemic vasculitis, even though they have complete clearance of the virus. So there may be some permanent changes in the immune system, B cell activation, that has not been totally abolished by eradication of the HCV. So this is going to have to be the subject of further prospective studies. But that's where we're at as far as I know right now. And again, I haven't been involved in any inpatient stuff for quite some time. Is one more slide? No, I think that's it. So, okay, hope I didn't go too long there. Okay.
Thanks so much for that, Dr. Schlesinger. That was wonderful. I do have
So-
one question or comment. It's a comment and question for you.
Okay.
At ID Week, they mentioned that we're seeing less cryoglobulinemia and manifestations thereof from hepatitis C because we're able to so easily treat it. And I don't know if you've seen literature on what the average duration of chronic hepatitis C or B infection is before you acquire these manifestations? I
No.
think, I thought I heard it mentioned it was like a decade, but do you know?
Mhm. No, I don't.
Okay,
Yeah, uh, I should say that, many of the, methotrexate is our go-to drug so much for, people with mild to moderate rheumatoid arthritis, even in the era of JAK inhibitors and biologics that, we're very tuned to make sure the liver's okay. Jesse knows this patient that we just had who probably has had Hep B for years, but and was discovered because she had a relapse viremia. We certainly see patients that we think have been positive for a long time. And again, even with we have good antiviral treatment, but I think we still see patients who we think have RA. I don't think the Hep C necessarily had a lot to do with the pathogenesis of their RA. They happen to be HCV positive, and that positivity informs our choice of treatment, but I don't know that it had a lot to do with the disease course. Okay.
anyone else have
Okay.
questions? We have one case today.
Okay.
Any other questions?
You can email me too, hcmed.org if you have questions.
Great, thanks so much, Dr. Schlesinger.
Yeah, I can stay for the case, right? Yeah.
Okay, yeah, please.
Okay.
Great. Marcia, you ready to take it away?
Yeah, I sure am. Thank you. So my name is Martha. I'm a nurse practitioner at Healthcare for the Homeless. I am presenting today on a 61-year-old male who's had Hep C for over 30 years. He was initially diagnosed when he was incarcerated. Risks include IV drug use in the 1980s and non-professional tattoos. Interestingly enough, this gentleman actually has seen Jesse in the GI clinic. Last was in 2018 and just hasn't had follow-up from then. He is staying in permanent supportive housing at Higher Ground. So hoping that we might be able to kind of pick up where Jesse left off and update some things based on what's been going on over the last 4 years and get him treated. So he is, last time we did a ton of labs for him was last March. So some things are a little bit outdated. We did have some updated ones this past September. So his virus continues to be active. His last PCR was positive, was 374,000 back in September. As far as other significant lab works, things kind of looked okay for him. His AST was elevated at 62, or I'm sorry, ALT was 62, AST was 92. He's genotype 1A. Everything else looks pretty within the normal limits. He's immune to Hep A and to Hep B. He's HIV negative. He has had imaging done. So he did have a fibroscan done back when he saw Jesse in 2018. That was predictive of cirrhosis. That was the F4 category. His last liver ultrasound was also done in 2018. That showed some mild hepatomegaly. On exam, you can also, his liver does seem a little bit enlarged at like 3 to 4 fingers below his costal margin. Let's see. So his FIB-4 score was 4.05, which is also suggestive of fibrosis. He, on exam, he does have some swelling of his legs. So that's kind of the only concerning factor for, is he moving into a decompensated state that I'm wondering about. When he's come into clinic, he really only comes in. I think he's using alcohol more frequently than he's admitting. He's come in a few times after he's crashed on his bicycle. He's well enough to ride a bike, which is great. But he's kind of had these like just abrasions that have turned into cellulitis. And so she's come in just for more acute things most recently. But I think he is drinking alcohol. His comorbid conditions are schizoaffective disorder, in which he's currently on olanzapine for. He's has a history of a stroke, maybe on aspirin. I'm not sure if he's taking it. And he does have a history of a brain injury also. He's got obesity, mental health conditions of comorbid PTSD and nightmares. So one of the biggest challenges in treating him is he is like absolutely opposed to swallowing pills. He wants his Hep C treated, but he's absolutely opposed to swallowing pills. So even with his olanzapine, I think that's probably the only medication that he's regularly taking. He's on or olanzapine oral disintegrating tab. Who knew there is even one? And like for his, when I treated him for cellulitis for his legs, I actually ordered like liquid antibiotics for him to take. So when he saw Jesse back in 2018, it was advised that he'd be on GP for 12 weeks. But in looking at the alternatives to the actual pills for the Hep C treatment, it seems like there's pellet forms that are available. Although, and if you think about kind of not quite decreased pill burden, but decreased pellet burden, the GP would require 6 packets of pellets per day, which just seems like a lot. Versus the Epclusa, the Sofel, would be 2 packets of pellets per day. So I guess some of my 2 questions are, one, he's got some swelling in his legs. I'm assuming he's got, fibrosis with some cirrhosis. Is he starting to be kind of decompensated? I'm not quite sure. He is the Child-Pugh class A. So I think we can still just call him call him compensated. And if that is the case, is there kind of a preference between the GP and the Sofel, given pellet burden? Or if anybody has any tips or tricks for using pellets, both getting them covered by insurance and also taking them.
Great questions. We have Maggie Rico on the call. Maggie, do you have comments on the different options?
So my ignorance, I didn't realize that Epclusa came in pellets. I've had a few people who've used the Mavorite pellets, and I was not yet aware that Epclusa had that option. I don't know. I guess I'd like to hear from our GI from the other clinicians if we want to call them compensated versus decompensated, because to me that's what's gonna like, it's a PA no matter what, and we're going to need to get special approval no matter what to get the pellets covered. And do we have a strong reason to do Sofel versus GP?
Yeah, Jesse?
I do have a question. What is the reason that he cannot swallow pills? Is it anatomically he cannot swallow pills? What is the reason? I don't know if I'm not misunderstood.
I know. I didn't really go into it. I think it's his own aversion. Like we've tried to coach him through things before and he chokes. And I mean, this has been like ongoing. We've been trying to get him to take aspirin for a history of a stroke, and he can't do that. So.
But when that's just as powerful as anatomical in my mind, because if
Yeah.
he's not going to swallow pills, he's not going to swallow.
No. Right.
It's like-
Right.
So you got to think of alternatives here. And I think pellets it's just become a big issue. I mean, in the last 3-4 months, I had this come up, I think, 4 or 5 times or something. It's like, yeah, it'd be interesting. I've gone for years without worrying about this, and then all of a sudden we've run into a lot of cases where people are having a hard time with the pills, and no wonder why he never came back to me. I told him to take BP. The highest pill burden regimen he could take. So I'm glad that he came back to you and was like, interested in pursuing it this way. I think your question about decomp is tough. And I think whenever we see lower extremity edema, we start to worry about ascites equivalence, and it can be a little bit challenging to understand if that's truly, related to his liver or something else. I just kind of listening to his history without ever seeing this guy with my own eye. Well, I guess I did, but it's been a while. I don't remember him at all. But he sounds like he may just have some venous insufficiencies with this, like
Yeah.
past vascular diseases, obesity and stuff may just be more, typical swelling from that point. And I would probably lean into that. He's got pretty good albumin. His platelets are a little bit low, but they're still like well above 150. So is suggestion of like advanced portal hypertension is low to low suspect. So I would say he's compensated, and and I guess using Epclusa sounds a lot easier, like less of a burden anyway. So you can kind of feel I would pursue that, then you don't have to worry so much about this being maybe some sort of early decompensation, even though we don't think it is, but you'll be in the safer realm with that medicine. Plus like 2 packets versus, was it 6 or 8? I can't remember.
6. Yeah. Well, and I guess I don't know, like, I'm assuming 2 packets is less than 6 packets, but I guess I don't know the volume in each packet either. Yeah.
I've asked that a couple of times. I want to see them. I haven't seen them, but I have asked that, and I don't think it's very much. Like they say you can put it on a small amount of applesauce or yogurt or something like that, and it's not like it's this huge volume. But I haven't physically seen the packets. The Mavorite, I've been told that they're kind of bitter, but you just swallow it real fast and it's done and over. Louisa, I don't know, have people told you anything different?
Yes, Jamie this from Fairview mentioned that they're bitter, so once the packet is open, they need to kind of take it right away, because otherwise the taste is very nasty and patients don't like it.
He sounds like a guy that the least complicated path is probably going to be the best too. So I guess I would, you got you and like Maggie or you kind of guys can kind of work more on like volume of each one and kind of decide which one might be the most straightforward like treatment plan for him. And I would, because I don't really feel too strongly about one of the medicines over the other. I don't know about you, Amanda, or anyone else. If you feel really strongly you should be on Epclusa, I think that Sofel or GP would be fine for this guy. But
Yeah, I'm with you. I'm totally with you. I wouldn't give him ribavirin.
Okay.
Yeah. Okay. We got to wrap it up
comes
though.
in pellets anyway. I don't know.
Yeah.
And then last thing for just because of that like question of maybe decompensation versus compensation, do labs monthly during treatment?
I would, yeah. I mean, you think he has cirrhosis anyway, so I'd probably be checking labs at at least at 1 month into it, and then at the end of treatment if you.
Okay.
Depending which one you do.
Okay. Sounds good. Thank you.
Thanks, everyone. Have a beautiful week.